Hi, my name is Marie Romagnano, founder of Healthcare Professionals for Divine Mercy. I'm so happy to present to you our educational conferences that integrate medicine, bioethics, and the spirituality of Divine Mercy in patient care for healthcare professionals. Because of their importance, even if you're not a medical professional, we invite you to join us. Today, I wish to offer a summary of a presentation given by Elene Viscosi, who discusses end-of-life management of cancer patients and spiritual care. Elene is a nurse practitioner at the Center for Head and Neck Cancers at the Massachusetts General Hospital in Boston, Massachusetts. She offers a unique perspective on the treatment and care of Father Mark Garrow, a Marian father who died of cancer in 2007 at the age of 52. She addresses the spiritual concerns in end-of-life situations with cancer patients. Cancer is the most feared diagnosis, and healthcare workers must strive to provide the best care that encompasses physical, emotional, and psychological dimensions. Over 1.3 million cases of cancer are diagnosed yearly in this country, and the overall 5-year survival is 62%. Yearly cancer is the cause of death in 25% of the cases. End-of-life management is defined as living with an illness that will cause eventual death. Care of end-of-life issues should involve prevention and treatment of pain, emotional support, giving respect and maintaining the dignity of the patient, and completing advance directives so that the patient's wishes are fulfilled. Attention must also be paid to the spiritual and psychosocial concerns of the patient. The goals of medical management of the terminally ill should center on ensuring a peaceful death, promoting the dignity of the patient, managing pain, instilling hope, providing knowledge of services available, and empowering the patient so as to maintain his or her sense of autonomy. Also important is listening and being present to the patient. Surveys have shown that patients want information so they can make an informed decision, support from family and staff, maintain their hope, in other words, overcome hopelessness, maintain their decision-making ability, keep their dignity, have their pain controlled to be able to manage their time left, and determine the place of death if possible. Pain is a complaint of over 85% of these patients and is not always effectively managed in many cases. A common mistake is waiting for patients to ask for pain medicine instead of regular administration so their pain threshold does not come too high. We must titrate to optimum comfort and even modify the route of administration if needed. There are non-pharmacologic treatments, pharmacologic, and radiation treatments if there is advanced bone or brain metastases. Dyspnea is another distressing symptom, and less than 20% obtain relief through treatment. Fatigue is another symptom and poorly understood, and this is described as constant and not relieved by rest. Delirium can be due to metabolic causes, hypoxia, infection, central nervous system disease, or medication-induced. Depression, anxiety, and a sense of sadness are common complaints. As the dying process ensues, fear, guilt, despair, doubt, and regret can be seen. It is important to remember that the human being encompasses mind, body, and spirit, and healthcare workers must strive to meet all the needs of the patient. A good treatment plan that encompasses a spiritual care plan is essential in the overall care when dealing with patients in the final phases of their lives. I invite you to listen to the full presentation of Elene Viscosi as she discusses end-of-life management of cancer patients and spiritual care. Thank you.
I'd just like to take a moment to thank Marie Romagnano and Father Cass for the invitation to speak to you this morning. And it was definitely our pleasure and our honor to take care of Father Garrow. He was truly incredible man, even though we didn't know him for very long. He approached his cancer and the end of his life with truly amazing grace, acceptance, and great spirituality, which extended to everyone, his family, his friends, to us as his healthcare providers, and to many patients that he came into contact with at Massachusetts General Hospital. So my talk is devoted to end-of-life medical management of cancer patients and spiritual care. And my talk is a little bit more medical than the talk that preceded me, and I hope you'll bear with me as we go through it. So why is this an important subject? Cancer is a very prevalent disease and one of the most feared that one can be diagnosed with. It challenges every aspect of an individual's life, their physical dimension, their emotional dimension, and their spiritual dimension. In the United States, approximately 1.3 million cancers are diagnosed. The cure rate is, however, improving, which is good news, and the 5-year survival rate is approximately 62% for all cancers. On the flip side of that, the bad news would be it is the second leading cause of death, and it's projected to cause greater than 560,000 deaths in the United States in 2008, which means that 1 of every 4 Americans will eventually die of cancer. So on the other side of that 62% is the 38% who will die. So what exactly do we mean by end of life? I think it just helps to start with a brief definition, which is a phase of life when a person is living with an illness that will worsen and eventually cause that person's death. And that period of time is not really limited to the time when a patient is moribund, which is really in the last few hours of life. It actually extends to months, to weeks, to the hours before the death. So what are some of the essentials of end-of-life care? It would be to prevent and treat pain and other symptoms. It would be to support the families and the caregivers of the patient. It would be to provide continuity of care through the whole journey through the cancer experience. It's to ensure respect for that patient, the family, and to help them make informed decisions in how they would like to proceed through the cancer diagnosis and treatment. It's also attending not just to the physical side of their disease, but to their existential and spiritual concerns. And it also would be to address what their wishes are at the end of life. So we as caregivers must spend some time helping them complete their advanced directives. So in order to do this, it's nice, just like with any medical management in any disease, to have some guidelines to help us do that. So why are they important? They help us choose the appropriate time for a referral to hospice or a referral to the palliative care team. It's a reminder to us as healthcare providers to ask about and address that patient's spiritual and psychosocial concerns. It's important for us as healthcare providers to know how to do this. So it's actually very important for us as healthcare professionals to incorporate it into the curriculums of nursing and medical schools. Research, as Dr. Thatcher alluded to, has shown that religious beliefs and spirituality are very useful and beneficial to patients and their caregivers. Medicine must incorporate these scientific findings into clinical practice in order to ensure better patient care. Unfortunately, the current national guidelines and 9 life-limiting conditions are pretty lacking in end-of-life content. Most of them do acknowledge the mortality of the disease, but little information exists in the palliative care aspect. The guidelines tend to focus more on disease symptomatology than actually the symptoms that need to be addressed during the dying process. The least addressed domain in those guidelines appears to be spirituality, with some not even mentioning them at all. And in those that do exist, only about 14% advise physicians to consider palliative care at any specific point in the disease process. So as healthcare providers and caregivers, what are some of the goals for us in medical management of end-of-life care? One is to facilitate a peaceful death. I think we all would like a good death with lacking in suffering. To maintain our bodily integrity, which is very wrapped up in our dignity. We want to instill hope versus hopelessness. We want to provide excellent pain and symptom management. And we need to possess the knowledge and the competencies to deliver that care in a coordinated manner. We also must empower our patients so that they have a greater sense of control over their illness and death. I think many of us get wrapped up in trying to make decisions about which chemotherapy and when, and often omit the fact that patients do not want active treatment at some point in their disease process. So what are the healthcare provider skills that are essential in meeting those goals? I think everybody would agree that listening is the most important, and that means listening without having a ready answer. Communicating effectively with both the patient and the caregivers and their families. Being there is incredibly important. Having just lost my mother 2 weeks ago, this was brought home to me. Just sitting there, somebody holding my hand, asking me if I'm okay, meant an enormous amount to me. At a time when it was more important for comfort than the actual medical piece. And knowing how diverse the United States would be, it is actually extremely essential that we are cognizant and respectful when we provide our care in a culturally competent and respectful manner. And respecting any rituals that those individuals may have that may differ from our own. And as we move along the end-of-life process, we must also anticipate what the needs would be of those that will be bereaved. So what do our patients want? They want information so they can make informed decisions. They want support from us as healthcare providers. They want to maintain hope despite a terminal diagnosis. They would like to sustain their social relationships. They want to maintain their decision-making ability for as long as possible. Want to protect their dignity. I think everybody's worried about what's going to happen to them as they near the end of life. They want to have their pain and other symptoms controlled. They do want to manage how the remaining time is spent and where that remaining time is spent. And most everybody we take care of talks about not wanting to be a burden on their family. They want to control the dying process. They like to be active participants in making preparations of their death many times, but not always. And they'd like to choose the place of death if possible. So choosing the place of death is a complicated issue. And I think the most important aspect of that is it depends largely on the complexity of the needs of the patient and what their personal preference is. Several studies have shown that most patients do want to remain at home if at all possible. But that is largely dependent on the availability and the ability of the caregivers. Many patients, again, as I talked about a moment ago, do not want to be a burden to the family, which then raises the issue, if the patient doesn't die at home, where should they spend their last moments? Should that be in the hospital? Should that be in a hospice home? And a lot of that depends on the issues of trying to maintain the best quality of life and where can they get the best quality of health care. So when I think about what dimensions are involved in the end-of-life management, one must address the physical component, the psychological component, and the spiritual component. And just to touch briefly on some of the physical symptoms that are probably the most prevalent at the end of life, I'm going to address the ones that I think are the most distressing and the ones that are the most challenging to take care of. I'm not going to spend a whole lot of time going through every single medication and diagnosis because I think each one of those symptoms could be a lecture in themselves. So I'm just going to try to highlight some gems and a broad overview of each one. So we'll start with pain, which is one of the most prevalent symptoms, and it's reported by approximately 80% of all terminally ill patients. Unfortunately, as good as healthcare is and as good as our skills are, many times pain is not effectively managed. And I think there are two mistakes that most of us make when we talk about pain management. One is we do not titrate to optimal comfort because we're so focused on what is the respiratory rate, what is the blood pressure doing, instead of looking at what the patient's actually feeling. And I think we also need to focus more on choosing the appropriate route of administration for that patient. And if that changes along the way, we have to have the flexibility to modify that. The NCCN guidelines, the palliative care guidelines, are excellent, and they have great algorithms to follow in these dimensions. So for those of you that would like more specifics, I would refer you to that. So when we talk about pain management, there's of course the non-pharmacological and the pharmacological approaches to taking care of this. The non-pharmacological measures, I think each and every one of us in this room are aware of. Heat and cold therapies can help, teaching the patient relaxation techniques, positioning, especially if there's a particular part of the body that's uncomfortable, and distraction, music therapy, imagery, massage, if the patient is comfortable enough to have that. And I think the key, and I use it a lot, is humor. I think it helps each one of us get through the process. As far as what medications are available to us in our armamentum against pain, there are four major drug categories in my opinion. First one being the nonsteroidals, which help decrease inflammation. Things like Motrin, ibuprofen, Aleve, the opioids or the narcotics, and they're given in a stepped manner. The bisphosphonates, which help alleviate complications of cancer therapy such as, or the disease process such as hypercalcemia and bony disease, and the radiopharmaceuticals, which are also helpful in treating bony pain. Radiation therapy, even though it's a much more invasive technique, is a useful modality in a patient who has symptomatic brain or bony mets, and certainly should be considered depending on what the situation is and what the life expectancy of the patient is. Dyspnea or shortness of breath is another very distressing symptom and very frustrating in trying to control. It's reported to be the second or the third most prevalent complaint for hospice patients. And in several studies I read, it's less than 20% effectively relieved through our interventions. So again, just stepping through the non-pharmacological and the pharmacological approaches to this, elevating the patient's head, fan to circulate the air, cooler temperatures in the room. Again, the use of relaxation techniques, trying to reduce any stressors that may be contributing to the patient's shortness of breath, and routine comfort measures. When we think about medications that can help relieve this symptom, the first thing we usually reach for would be morphine. And it is a very effective drug in helping respiratory distress and many times unrelieved cough. Oxygen is another medication that can be used for short-term relief in those patients that you can actually document hypoxemia. Benzodiazepines are very useful in helping treat an anxiety or an agitation component to the shortness of breath. And in patients who have lung cancer or other history of COPD or emphysema, some of the long-acting beta agonists could also be incorporated. The other issue in the respiratory system that impairs people's ability to breathe is excessive secretions. And we do have a few drugs that can help dry those up, such as the scopolamine patch, Levsin, atropine, which can be given in a variety of different ways. And if there is a component of fluid overload, one could consider giving some low-dose diuretics if appropriate. Every now and again, there's a situation where a patient has terrible fluid overload or pleural effusions from the disease process, and doing more invasive procedures may actually be helpful in that situation, especially if we're talking about weeks to months before the patient's demise, including procedures to remove the fluid like thoracentesis. Unfortunately, that's not a great tool because the fluid tends to reaccumulate, and every now and again, we've had to use pleural drainage catheters, and Dr. Clark and myself, actually about a year ago, had a patient who went home on hospice with this, and it provided tremendous relief in his remaining days and helped him enjoy his family. Fatigue is another symptom that is very well recognized. I think any of us who have taken care of patients know that this is a complaint that almost 100% of our patients report, but it's only recently become a major focus of research. And Carpenito, who's a nurse who's done a lot of research in this area, has helped to distinguish the difference between tired and fatigue. And tiredness, she believes, is transitory, but fatigue is pervasive and unrelieved by rest. And fatigue is usually not a symptom that happens by itself. It happens within the context of other types of distress, whether it's physical, emotional, or psychological. So how do we manage fatigue? You want to validate the patient's feelings, let them know this is normal, it is an expected symptom as the disease progresses. You want to try to correct any underlying causes or any contributing factors. You want to help them balance their rest and their activity periods so they can do the things they want to. If there are any medications that are contributing that can be stopped, we should give consideration to that. Unfortunately, many of the drugs we use at end-of-life care, like the narcotics and the sedatives, all contribute to this, so it is a fine balance. We do many times use methylphenidate, or more commonly known as Ritalin, to help counteract the fatigue associated with narcotics, and it is a useful tool for many patients. And there is usually a component of depression as one ends or approaches the end of life care. That's not true, of course, for everybody, but one could consider the use of an antidepressant at this time. So anorexia and cachexia, I find particularly hard to deal with in helping patients understand the disease process and trying to make decisions about supportive care as they approach the end, including things like intravenous fluids, total parenteral nutrition or feeding, the use of nasogastric tubes, the use of feeding tubes. So I think the best way to try to approach that is actually through educating the patient and their families so that they don't feel bad when these things are omitted. So you try to explain to people that most dying patients really are not cognizant of hunger and thirst, and that feeding them through an IV can actually hasten death because of complications such as infection and fluid overload, and that many of those symptoms, such as thirst or dry mouth, can be easily relieved and addressed by good mouth care, providing sips of fluid, ice chips, etc., and that it is ethically and morally okay to remove the IV or discontinue the nasogastric tube or stop using a feeding tube if one has it. Again, trying to support the family and the patient through this process by teaching them other ways to make the patient comfortable is very beneficial. So constipation, again, may or may not be a relevant factor in the end-of-life care. It is a frequently reported side effect, and I think every one of us knows how to treat that. So I won't spend a whole lot of time on it. Nausea and vomiting is another particularly unpleasant symptom and very distressing at the end of life. And it causes all kinds of distress, not just physical, but psychological distress, because patients are worried, and so are the families, that the patient's gonna starve to death or get dehydrated, which leads into the other issues of how invasive we should be. So we, of course, want to evaluate any of the possible causes and try to eliminate them. The most common causes would be chemical, such as metabolic abnormalities, infections, medications, such as the narcotics or big offenders, impaired gastric emptying in somebody who may have a malignant bowel obstruction, and visceral and serosal components, such as diarrhea, gastrointestinal bleeds, or constipation. And nausea and vomiting is a complicated component, and I think in order to know which drugs to choose, one must have a brief understanding of the 4 pathways that nausea and vomiting occur. And the first one is the chemoreceptor trigger zone, which actually exists outside the blood-brain barrier, and it's triggered primarily by toxins in the blood or the cerebrospinal fluid. In the cerebral cortex, the input comes from our 5 senses, from feeling anxious, meningeal irritation in somebody who may have cerebrospinal involvement of the tumor, and increased intracranial pressure. From the peripheral pathways, it's triggered by things that are happening in our GI tract and our internal organs, and by the vestibular system, which is, receives inputs from the vestibulocochlear nerve within our ear, and that nausea and vomiting is primarily triggered by motion. So non-pharmacological measures, again, would include trying to avoid the triggers, using small frequent meals, relaxation techniques, and some patients find using those bands that provide acupressure helpful. From a non-pharmacological point of view, we always think about antiemetics as being our first line, and we all have great difficulty in choosing what drug should we use first because there are so many nausea medications out there. But when you look at the studies, there's actually been no head-on-head study to show that one nausea medication is better than the other. And an old tried and true, which I think works the best, is actually compazine. And it's a D2 agonist, and the other medications that fall in that category are medications like metoclopramide and haloperidol, which actually blocks that CTZ pathway, which is most commonly induced by narcotics. So one of the mistakes I think we make in treating people who have persistent or constant nausea is to write prescriptions for PRMing as needed instead of round-the-clock dosing. And if you've optimized the round-the-clock dosing and the person still is nauseous, then you should consider the addition of a second or third medication. And that can include a whole host of drugs that I have listed below. And in certain circumstances, the use of combination products should be considered, such as the ABHR suppository, which is a combination of many of those drugs: Ativan, Benadryl, Haldol, and Reglan. There is some information, I thought it was interesting, on herbal medications. I have not really used that in my practice, and there have been no studies that have really proven efficacy, but I think many patients try alternative treatments and medications, and that should be respected. And then, of course, if somebody has intractable nausea and vomiting, the use of palliative sedation is indicated. So delirium and terminal restlessness is another very difficult symptom that we encounter. And again, the causes can range from metabolic abnormalities to lack of oxygen, to bowel obstruction, to infection, to CNS disease, or strokes, or TIAs, or bleeds in the head, or medication. And the management, again, non-pharmacological, would be to try to provide a calm and reassuring environment and approach to the patient. You want to reorient them as much as possible. You want to keep their familiar surroundings and objects around them. You want to try to maintain regular routines, ensure their safety, and try to remove anything that may cause them harm. And support and educate the caregivers along the way, because they're the ones who have to watch the discomfort, and it can be extremely unpleasant. Medications would include things like haloperidol, risperidol, Seroquel. Ativan, in my opinion, is not a great drug to use in an already confused patient, tends to make that worse, especially in the elderly. And another technique that's often used is rotating the narcotics. So I'm just going to touch briefly on the use of terminal sedation. I believe there's a lecture to follow us that's devoted to that, but just to let you know that is an ethically and legally supported symptom management strategy. And what does that actually mean? It's the use of sedatives to relieve extreme, intractable physical distress in the final days of life. Its intent is to alleviate suffering by basically rendering the patient unconscious and not to hasten the death. So the psychological symptoms, to move on to the second dimension, include things like anxiety and worry, feelings of sadness, depression, which are very commonly reported symptom in about 77% of all patients with advanced care. And I am a great believer in treating this aggressively, because I think patients who are able to address that particular symptom tend to do much better emotionally and physically than those that do not. Fear, guilt over things they may have done in their lives, regret for things they may not have done in their lives. And this can exhibit in symptoms of insomnia, feeling irritable, and having trouble concentrating. So how do we address the emotional component of that? I think just as many of us would do. Listening, again. Touching, just sitting there and holding somebody's hand goes a long way. Expressing empathy, attending to their wishes as best possible, providing comfort, encouraging them along the way, and being present. Just to touch on depression a little bit, there are many ways to address that, both from a non-pharmacological point of view and pharmacological methods also. Psychosocial interventions would be education as to what the symptoms are, being able to identify them, and explain to folks what we can do to help make that better. So that can be done in a variety of different settings, whether it's with a social worker, a psychiatrist, a chaplain, clergy, support groups, many, many avenues. We can also use medications, which would include tricyclic antidepressants, which actually are useful in helping control some other symptoms like pain, neuropathic pain. Medications like amitriptyline can also be very helpful. The selective serotonin uptake inhibitors like Celexa and Lexapro tend to have fewer side effects and less interactions with other drugs. And medication like Lexapro actually can address any generalized anxiety component to the depression. So what are the spiritual symptoms? And I think I'm probably preaching to the choir, but just to touch upon it a little bit, it's questioning the credibility of their belief system, despair, doubts, spiritual emptiness, emotional detachment, expressing anger, resentment, or fear over the meaning of the suffering and their death. So what is spirituality? I really hadn't given this a whole lot of thought up until the time I had to write this speech, so it was very informative for me. And when I go to find what it actually is in the literature, there really is no absolute definition. Many definitions exist, but they all revolve around the idea of meaning in life and death, wholeness as a person, and your values. The NCI actually did have a definition, and they defined spirituality as having to do with the deep, often religious, feelings, beliefs, including a person's sense of peace, purpose, connection to others, beliefs about the meaning of life. And the definition that I particularly can identify with is the following: that which allows a person to experience transcendent meaning in life, often expressed as a relationship with God or other superior being, but can also be about nature, art, music, family, or community. Whatever beliefs and values give a person a sense of meaning and purpose in life. So who can be a spiritual care provider? Anybody. Could be family, friends, any person involved in that patient's care, chaplains, clergy, physicians, nurses, other healthcare providers, not to miss anyone, and pets for some people. I can't tell you how many times when I worked on the floors that one of the final wishes many patients had was just to hold their cat or just to pet their dog. And of course, we broke the rules and brought them all in. So is spirituality important? I would offer a yes. Why is that so? Cancer patients rank faith as a highly significant factor in their decision-making. It's essential in treating the patient as a holistic human being. It helps provide us as healthcare providers reconnect why the reason we chose our jobs in nursing or in medicine as healers. And there is actually scientific studies that help support that spiritual well-being in cancer patients does correlate with improved quality of life. And failure to meet those needs actually leads to lower satisfaction with health care and a perception the patient has not gotten good quality care. And if all else fails, we can always rely on the Joint Commission to give us a good reason. It's actually mandatory to do a spiritual assessment. So what role does spirituality play for patients? It provides a framework for finding purpose and meaning in their lives. It provides a sense of control over feelings of helplessness. It offers hope and emotional comfort. It helps them overcome their fears. It helps provide effective coping mechanisms not only for the patient, but for the caregivers. And it does help improve quality of life. Again, several studies out there that have shown that. And that's much more important now as treatment advances have helped extend survival. And unfortunately, that hasn't made it all the way into medical practice yet, because many of the quality of life components that we do to our studies do not even include spirituality as one of the domains to measure. So why is it omitted? Well, it could be lack of education. It could be our lack of expertise. It could be lack of comfort. Addressing spirituality is, I think, a very challenging, very personal, and very individual component. Many of us are not even self-aware of our own spirituality, so it's very difficult to help your patient through that process. And I think the biggie factor for us as healthcare providers now is actually lack of time. That's a subject that you cannot address it in 5 minutes. So again, using other healthcare providers to help you accomplish that is very helpful, such as the chaplains, the clergy, the palliative care team, social work, psychiatry. So how do we assess spirituality? Well, there are many, many tools out there, both quantitative tools and qualitative tools that are all validated instruments. And I think when I look at those tools, I think, wow, those questions are really awkward. I can't even possibly imagine myself asking that point blank to a patient. So I think when you look at those tools, you should use them as guides to help stimulate discussion and help lead questioning. Just a few of the qualitative instruments that are available to us, and the one that I particularly like is Mogan's Spiritual History, which is an acronym, which is just a nice, easy reminder as to the subjects to talk about, and you can see them up there. The S standing for, does the patient have a spiritual belief system, whether that's in a framework of religion or not? Is the person spiritual in their own right? Are they part of a spiritual community? Do they have ritualized practices and restrictions? And how can we help support that? What are the implications for our medical care? And how does that lead into terminal care planning and advanced care directives? Quantitative measurements, just a few. Again, I like the simple one, the FICA, which the F stands for faith and belief systems. What is the importance of the person's spirituality? Does the patient belong to a spiritual community? Do they wish to continue participating in that, and how can we make that happen for them? And how would that patient like their spiritual needs or religious beliefs addressed? So what have I learned after 26 years in medical oncology? That it is extremely difficult. It's often frustrating and many times sad, but I cannot actually imagine doing anything else in life. I feel honored, incredibly rewarded, inspired by my patients every single day. Their strength and their wisdom is humbling. My patients have been the best teachers. They're the ones who have taught me how to help them get them through the journey of life and my own. We all search for meaning, purpose, and value in our lives. Thus, we all have spiritual needs, whether we realize it or not. And failure to meet those needs causes distress. And what do I think at the end of the day? How do I know I've done a good job? Well, I think I've done a good job when I've been able to meet their physical, their psychological, their social, spiritual, and practical needs in their own culturally respective and appropriate manner. That's not so easy sometimes. I think many of us in healthcare would acknowledge that many patients have not addressed their spirituality, their belief system, or their values. And now faced with their mortality, they have that incredible challenge. And we're the ones who are there to help them get through it. Those are the patients that, even though they're dying eminently, can't decide on code status, can't decide where they want to be. And those are the patients that are the most challenging. My motto at the end is one day at a time. And I did have a clip up here, but I can't actually do it without internet connection. But I will end on that note. Thank you again.